So the A.R.R.O.W study is a Phase III randomized trial conducted in relapsed and refractory myeloma patients after 2 to 3 prior lines of therapy, including prior exposition to proteasome inhibitor and immunomodulatory drugs, in which Carfilzomib 27 milligrams per square meter twice weekly, that is the conventional approach, was compared with Carfilzomib at a dose of 70 milligrams per square meter, but given just once a week. The primary objective of this trial was progression-free survival, and a couple of years ago the primary objective was met, and Carfilzomib 70 milligrams per square meter once weekly demonstrated to be superior to Carfilzomib 27 milligrams per square meter twice weekly. Myeloma usually affects to the elderly population, and in the A.R.R.O.W study, approximately 50% of the patients were older than 65. So what we wanted to evaluate was what was the efficacy and the safety profile of Carfilzomib 70 milligrams per square meter weekly versus Carfilzomib 27 twice weekly in the elderly population. But also we know that the elderly population in myeloma is a truly heterogeneous population, and we decided to use a geriatric scale in order to distinguish between fit, intermediate, and frail patients. For doing this, we decided to select the International Myeloma Working Group frail scale based on the chronological age, on the Charlson Comorbidity Index that we did an approximation to this scale, as well as the activity daily living and instrumental activity daily living. With this background, we had the opportunity to see how approximately 30% of the patients included in the A.R.R.O.W were frail, 25–30% of the patients were fit, and approximately between 35 and 40% of the patients included in the A.R.R.O.W were intermediate. When we evaluated the efficacy in terms of progression-free survival according to the frailty score, we had the opportunity to see how Carfilzomib 70 milligrams per square meter once weekly was always superior to 27 milligrams per square meter twice weekly, regardless of the frailty score. And the hazard ratio for progression-free survival was maintained across the different subgroup of patients. It's true that the fit population had the highest benefit, and in fact the hazard ratio was approximately 0.5. So this group of patients would be the group of patients who benefited the most from Carfilzomib 70 weekly. In terms of overall response rate and the different responses category, we had the opportunity to observe the same effect, and Carfilzomib 70 milligrams per square meter was always superior to 27 twice weekly. And most importantly, we were dealing with the elderly population, and we evaluated also the safety profile and the incidence of treatment emergent adverse events, as well as grade 3–4 treatment emergent adverse events, and adverse events leading to discontinuation of the study were equally balanced between Carfilzomib 70 and Carfilzomib 27, and across the different subgroup of patients according to the frailty. In fact, when a specific adverse event of interest like cardiac failure, hypertension, or acute renal failure were evaluated, no significant differences were observed. So the main message of this presentation of this sub-analysis conducted in the A.R.R.O.W study is Carfilzomib 70 milligrams per square meter once weekly can be delivered to every relapsed and refractory myeloma patients older than 65, regardless of the frailty score, and it can be delivered safely to patients with a fit status, intermediate, or even the frail population.